Okay, let's go ahead and get started. So good afternoon and good morning to everyone and Happy New Year. I'm Brenna Rabel. I'm the Technical Director of Patel's Partnership for Quality Measurement, and I am very happy to welcome you all to this year's Pre-Rulemaking Measure Review Clinician Recommendation Group meeting. I want to just start by extending my very sincere thanks to each of you for volunteering your time and expertise to be here, especially those of you who signed in bright and early to also join the roundtable discussion that we had earlier today. Your commitment to this process is so crucial to us, and it's really what makes this work possible. I think most of us are aware that this past year has been an atypical one, particularly with the government shutdown that impacted the MUC list publication timeline. And because of that, this year's meeting is going to look a little bit different than in the past. You're going to hear from Meredith, Kate, and Lydia a little later, and they're going to walk us through some of those changes in a bit more detail. But I think what's most important is that we are all here today ready to continue this really important work of reviewing and recommending measures that'll drive quality in U.S. healthcare. Your contributions directly shape the standards that will, we hope, improve care for patients across the country. So thank you again for your dedication. And let's just go ahead and get started, and we can bump to the agenda slide. Yeah, thank you. So we're just going to wrap up my sort of welcome here, and we'll do a process overview after our roll call. And then we'll jump right into our measure review, which will take us all the way through to the end of the meeting. So we have a lot packed into this agenda, but it's much more concise than it's been in past years. We have fewer measures in general. So we're looking forward to a really robust and efficient conversation. Next slide. One more. So as you all know, today we are here to dive into the measures that were submitted for consideration to a clinician program for the 2025-2026 primer cycle. And to make that discussion as productive and efficient as possible, we just ask that you keep yourself on mute throughout the discussion until you're ready to make a comment. You can use the hand raise feature to let the facilitator know that you'd like to chime in. And once you're called on, you can go ahead and unmute yourself to speak. Once you've finished your comment, be sure to lower your hand and remute yourself. This just really helps us keep track of our queue of commenters and also to minimize distracting background noise. And then if possible, do try to stay on video throughout the discussion parts of the meeting. It just helps to foster discussion and relationship building. And then finally, feel free to use the chat in Zoom to communicate with Patel staff. And if you're having any technical issues with Zoom itself, you can always let us know that via email at pqmsupport@patel.org. We have folks that are actively monitoring that inbox, so we should be able to help you troubleshoot quickly. Next slide. So again, we have lots to discuss in the relatively short time that we have today. And to make sure we're streamlining our discussions, we just kindly ask that you please keep your discussion points and questions limited to issues that could potentially impact your recommendations. We also ask that you sort of try to follow the process. We're going to lay it out for you, the order that we're asking people to comment. And we just ask that in general, you adhere to our community guidance for these meetings. So that means, of course, respecting all the voices on the line, including the measure developers who are here to help answer questions, remain engaged and actively participate throughout the discussion, but also keeping your comments concise and really focused to the issues at hand. Of course, being respectful of everyone's time and allowing others the space and opportunity to contribute. When you are contributing, please be, forthcoming and generous with your expertise and experiences. And of course, as always, take the opportunity to listen and learn from the others that are on the call. Next slide. I think everyone here is aware that we live in a pretty acronym-rich environment, and sometimes that can be a little bit frustrating. So we just wanted to include kind of the most common ones that you're most likely to encounter during these calls here. Feel free to just hang on to this slide and keep it on the side to reference for later if needed. Next slide. Just quick intros here. So you already know me, and you're definitely going to be hearing from Dr. Meredith Eastman and Kate Buchanan later on. They are my co-facilitators today. They are also the primer task lead and deputy task lead, respectively. You'll hear from Dr. Lydia Stewart-Arks, who handles all of the evaluations on the Patel side. And then my colleague Isaac Seiji is our lead analyst who's going to be supporting our voting today. And then, as always, I wanted to acknowledge Dr. Michelle Schreiber at CMS, who you'll hear from, as well as the rest of the CMS team that helped get us to this point. Hella Dollar Maples, Nidhi Singh Shah, Charvan, and Mel Gross, as well as the many, many CMS medical officers and leads that support this work. All right, next slide. All right, I'm turning things over to Kate Buchanan to take us through roll call and your DOIs.
Thank you so much, Brenna, and welcome all. So we are doing things a little differently this year. As you noted, we do have our AG members and our RG members on the same meeting. If you can't remember if you're AG or RG, which we understand it does change from year to year, if you look like next to your name, you'll see an AG if you're part of the advisory group, and then an RG if you're part of the recommendation group. We are incredibly appreciative for all being on, but because we have to, because it's only the recommendation group that votes, we do have to do verbal disclosures of interest as well as attendees for those recommendation group members. We do ask if you are an advisory group member to please introduce yourself prior to providing a comment when we get to that time. So we have two disclosure of interest forms. We have a general one as well as a measure specific one. And it can be a little challenging at times to figure out which ones to send if you've already sent them. So I am going to note if we need your measure specific DOI or your general DOI. My colleagues are going to put in the chat the link to the measure specific DOI as well as the attachment for the general DOI and where to email it. We do need those DOIs prior to voting, so we really appreciate your cooperation. The other thing I'll note is if you are on an attendee side, but you are supposed to be a panelist just means that you can talk. You may see an invitation to promote to panelist, and so we ask that you accept that. The last thing I'll say is that we have a default for our chat that says hosts and panelists, but we encourage you as we get into the comment section and the measure discussion to select everyone so that everyone is able to see that. So there is a change to our policy as compared with last year. If you have a conflict of interest, you do verbally disclose it on this call, but you are allowed to participate in the measure discussion. You are not allowed to vote, though. In years past, you couldn't participate in the measure discussion or vote, but now it's just voting. And as I go through introductions, I am going to ask you to introduce yourself, which organization you're from, if applicable, and I'll let you know if we have any outstanding DOIs for you. Next slide. Okay, so I'm actually going to start with our committee members, and then our co-chairs will do an introduction later. And I'm going to also apologize ahead of time for any mispronunciation. Ramsey Abdallah. Okay. Rose Baez.
Hi, Rose Baez. I'm from Blue Cross Blue Shield Association, and I'm the Senior Director of Clinical Quality and Measurement.
Great, thank you. Mary Balaker. Okay, we'll wait for Mary. Reggie Barnes.
Reggie Barnes, patient, and also Director of Patient Partnership for the Autoimmune Registry.
Great, thank you. Stephanie Braxton.
Hello, Stephanie Braxton. I'm a senior manager at the American Academy of Dermatology.
Thank you. Zishan Butt.
Hi, good morning. Zishan Butt. I go by Z, representing the American Psychological Association.
Great. And Z, we need your general DOI as well as your measure specific DOI. And so they are, links are in the chat, but please reach out to us if you have any issues.
Thanks. I thought I submitted them, but I will do that now.
Thank you. Matthew Saracel.
Hi, I'm Matt Sarcel. I'm an adult hospitalist and a representative from the Society of Hospital Medicine.
And thank you. And Matt, we do need your general DOI.
Like
So if
right
you
now?
could send, thank you. And then Aaron is unable to attend. Jonathan French.
Hello, everyone. Jonathan French, Senior Director of Public Policy and Content Development with HIMSS, where I manage our quality reporting and measurement public policy development. Thank you.
Great, thank you. And Jonathan, if you could complete both of the DOIs, we'd appreciate it.
Yeah.
Barbara Goodman. Barbara may have to join us a little late. Ashraf Harshay. And he, I think, had a clinical issue come up, so he will be joining shortly, but is not here just yet. Rich Heller?
Rich Heller, I'm a pediatric radiologist. I'm the Senior Vice President for Health Policy at Radiology Partners and a clinical associate at the University of Chicago.
Great, thank you. And do you have any disclosures?
I do not.
Okay.
And you have my forms.
Yes, we do.
You do. You have my.
Thank you. And Buffa? Don't see Ann on yet. Oh yeah, Ann is on. Ann, could you unmute? Okay. Can't hear you, so it appears you're having some audio issues.
Is that
There you go.
fabulous? All right. Hi, Ann Baffa, Vice President of Population Health and Network Quality Strategy for CCA, which is a decent plan in the Massachusetts space. I oversee public reporting, accreditation, and all things STARS. So excited to be here today.
Great. And do you have any disclosures of interest?
I do not.
Okay. And I'm realizing I think I forgot to ask for verbal DOIs for a couple of our members. So I'm actually going to go back a little and then just ask you to verbally disclose. Reggie, do you have any conflicts of interest?
No, I do not.
Thank you. Stephanie Braxton?
I do not.
Okay. Z?
I don't. Thank you.
Okay. Matt? Matt Saracel, do you have any conflicts of interest?
I have no conflicts of interest.
Thank you. Jonathan French?
I have no conflicts of interest.
Thank you so much. Appreciate it. Okay, now we're back on. John Hitchens?
Number one, I have no conflicts. I am a certified registered nurse anesthesiologist, and I am representing the American Association of Nurse Anesthesiologists.
Great. And John, could you also complete your 2 DOI forms in the chat?
You bet. Thank you.
Thank you. So then we have Deirdre Mylod.
Hi, Deirdre Mylod, representing Press-Ganey. I'm the Executive Director of our Institute for Innovation and SVP of Research and Analytics, and I have no conflicts.
Thank you very much. Diane O'Connor.
Hi, I'm Diane O'Connor. I'm the Executive Director for Patient Safety and Quality for the Johns Hopkins Health System, and I have no conflicts of interest.
Thank you. Tipu Puri.
Hello, Tipu Puri. I'm an adult nephrologist, and I'm here as an independent clinician.
Great, thank you. And could you complete both of the DOI forms?
Sure.
Thank you.
And I have no conflicts of interest.
Wonderful. Amir Kassian? Don't think Amir's on yet. Okay. Megan Reyna?
Hi, Megan Reyna. I'm the Chief Operating Officer for Population Health at Bon Secours Mercy Health, and I am the National Association of ACOs representative. I have no conflicts of interest, and I did complete the measure-specific one just now, so hopefully—
You preempted me. Thank you, Megan. I appreciate it. Christine Roger?
Hey, this is Christine Rager. I'm a consultant with Kaiser Healthcare Solutions, and I don't have any disclosures.
Okay. And could you please fill out both of our DOI forms?
Sure.
Thank you. Corinne Rubin?
Hi, Corinne Rubin with the American Medical Association, and I have no disclosures, and I completed the DOI form, so it should be okay.
Thank you. Jeff Sussman?
Hi, I'm Jeff Sussman. I'm a family physician geriatrician. Here is a independent clinician, although I've been very active with the American Academy of Family Physicians. I have no conflicts of interest, and I believe I've submitted my forms.
You have. Thank you.
All right.
Bradford Tinloy?
Hi, Bradford Tinloy. I'm an emergency physician. I'm representing Vituity, which is a multi-specialty national physician partnership. I don't have any conflicts. I just emailed the general DOI and I did the measure one previously.
Wonderful. Thank you. Michael Tote?
Hi, I'm Michael Toad. I'm an independent family physician. I have no conflicts of interest, and I submitted my forms this morning.
Wonderful. Kayla Waldron?
Hi, I'm Kayla Waldron. I'm the Director of Medication Use and Quality Improvement with the American Society of Health System Pharmacists. I do not have any disclosures, and I just did both of my forms.
Great, thank you. And I am realizing, Jeffrey Rose, I apologize. If you wouldn't mind introducing yourself and doing any disclosures of interest.
No worries. Jeffrey Rose, cardiologist representing the American College of Cardiology. I have no disclosures.
Thank you so much. Jennifer Woodward?
Good afternoon. I'm Jennifer Woodward. I'm a family medicine physician representing the American Academy of Family Physicians, and I also am the associate CMIO at the University of Kansas Health System.
Thank you. And Jennifer, I know that you messaged about your DUIs. We just need your general one. So thank you.
General one. Got it. Thank you.
Thank you. Wei Yang?
Wei Ying, Senior Director of Performance Measurement and Population Health Analytics at Blue Cross Blue Shield, Massachusetts. I have nothing to disclose.
Great, thank you. And Wei, could you please complete both of the DOI forms?
Oh, okay, will do now.
Thank you so much, appreciate it. And then I believe we do have Mary Balker on the line, but Mary, I think you had some audio issues earlier. Are you able to introduce yourself and provide any disclosures of interest? Okay, Mary, we'll work with you on that. And then I'm looking to see if anyone else has joined. Do we have Ramsey? Okay. And then I know Ashraf had a patient, and then Barbara. Oh, Barbara Goodman, can you please introduce yourself and provide any conflicts of interest?
Hi, I'm Barbara Goodman. I'm in home health and hospice space mostly. I've been in post-acute care for it seems like my entire life, but I have no disclosures.
Great. And Barbara, if you wouldn't mind in the chat, we have the 2 disclosures of interest form. If you could complete those, we'd greatly appreciate it.
Okay, thank you.
Yes. And so welcome all. Thank you all so much. I am going to turn it over to our co-chairs soon to provide some introductory comments. I will say our clinician co-chair did have an emergency patient issue, and so he will be joining as soon as he can. But we very much understand that patient care comes first. With that, I'm actually going to turn it to the next slide and ask our co-chair, Krista Starkey, to introduce yourself.
Good morning, and thank you for having me. My name is Krista Starkey. I'm here as a patient and a primary caregiver for a very complex kiddo. I'm also a graduate of the Texas Partners in Policymaking Program, class of 2020. I represent the Family Advisors Network with Children's Medical Center, and I'm just here because I believe that collaboration is what makes the difference. I'm very compassionate about the patient perspective, and that's what I'm here to offer.
Thank you so much, Krista. And Krista, if you wouldn't mind completing your DOIs, greatly appreciate it.
Absolutely. I'm sorry.
Oh, no worries, no worries. Okay, so then we go, I believe I'm turning it over to Dr. Schreiber for CMS opening comments. Next slide, please.
Well, thank you and good afternoon, everybody. For those of you who don't know me, although after 3 days, this is day 3 of primer, many people have. I am the Deputy Director of the Center for Clinical Standards and Quality at CMS, and I'm also the Director of the Quality Measurement and Value-Based Incentives Group. I am a primary care, general internal medicine physician by background and spent a lot of time in healthcare systems, Chief Quality Officer, Chief Medical Officer, Chief Medical Informatics Officer, so a lot of experience, but have been at CMS for the past 7 years. It is my delight on behalf of CMS to welcome you and really to thank you, to really express our appreciation for you being part of the pre-rulemaking committee and really the Partnership for Quality Measures. A few other thank yous, certainly to Patel, who's been doing a wonderful job in organizing and facilitating these meetings, to the CMS staff. It takes a village to put these together and do the work that goes into this. So to all of you, thank you very much, in particular to Mel Gross, who has been our leader and coordinator, to our measure developers, but most importantly, first to the co-chairs today. Krista, I'm glad that you said, what was it, collaboration makes all the difference. Couldn't agree with you more. And that's what we are here for today, is collaboration, these public-private partnerships that really offer an opportunity for CMS to hear from stakeholders and help weigh in on decisions about what measures should be used in our programs. And ultimately, obviously, what we are all trying to do collaboratively is to make healthcare and health better for all Americans. And to our other co-chair, whom I hope will join us later, Dr. Gopal. To all of you on the line, both the advisory group and the recommending group, really your participation is so essential. The feedback that we get does help inform CMS policy. I want you to understand that we are listening attentively, taking your comments into consideration. These will be valuable as we help draft the rules, especially in this case for the PFS rules, that's the provider rules, largely around the MIPS program, also MSSP, that start later in the year. So with that, and again, thanks to all, I'm going to turn it back to Patel.
Thank you, Dr. Schreiber. And our other co-chair has been able to join us. So Deepak, if you wouldn't mind providing some opening comments, we'd greatly appreciate it.
Okay. So thank you so much, Kate, and thank you, Michelle, as well as Meredith. And I also am grateful for Krista Starkey as my co-chair partner with this. And I think, just to kind of echo some of the sentiments, good morning, good afternoon, whichever time zone you're at. But I think just by introduction, I'm a gastroenterologist. I'm an interventional endoscopist. I'm here at the University of Wisconsin-Madison, been here for the last 23 years. I also, in our Department of Medicine, serve as a leadership role as the Vice Chair for Quality and Safety, and interact with the organization, including the Chief Quality Officer, quite frequently, with as well as other departments. So it's given me a unique perspective, but I think one of the key elements of patient quality, patient safety, as was noted, was the importance of collaboration, importance of partnership, and the opportunity to learn from each other, which is so key as we move on with important measures, quality indicators for consideration. So once again, I'm grateful for the opportunity to serve as a co-chair, and looking forward to the conversations and discussions today. Thank you.
Thank you so much, Dr. Gopal. And if you wouldn't mind just also verbally providing any conflicts of interest if you have them.
Yes. Okay. Yeah, I thought I completed the form, but none to.
We're just doing verbal ones.
Yeah.
So
yeah.
So it sounds like you don't have any conflicts of interest. And then if you wouldn't mind completing the general DOI, we'll reach out to you via chat for it. Okay, then we are moving on. So I'm going to turn it back over to CMS for some late-breaking clinician measure updates.
So just for context, I hope we're not catching anyone by surprise. This is about the advanced care planning measure and the status of that discussion.
Okay, thank you. I appreciate that. You saw that there are 3 measures for review. Those are actively being considered for the MIPS program. We have another measure that we just want to bring forward for discussion here as to whether or not this would be relevant in the future in a clinician setting. Some of you who may have been on the hospital call or on other calls may be familiar with the measure of advanced care planning. The advanced care planning measure is for patients 18 and older, and it's to assess whether or not patients have an advance directive. But to meet that requirement, you can also just designate somebody who is really that person's designee for making decisions for end-of-life care if needed. We'll talk more about it a little bit at the end, but I wanted to point out this is not for voting. But as we were talking about this in the hospital setting, it kept coming up over and over again that these conversations should be happening in the ambulatory clinic. So we're bringing this to you to see if you think these conversations belong in the ambulatory clinic. And with that, did I get all of it, Meredith?
Yeah, I think just to reiterate that this is not being considered for MIPS at this time. Is that
Correct.
true? Okay.
That is absolutely correct.
Perfect.
It is really the question before you is to feedback to CMS, is it appropriate to think of this measure for MIPS in the future? Now, so this measure is not being looked at for proposal in rules this year, but is this an appropriate topic for the clinician programs?
Great. I see we have a couple of questions. CMS, and Dr. Schreiber, would you be willing to entertain a couple questions about this?
Sure.
At this time? Okay, let's start with Jennifer Woodward.
Hi, thank you for that clarification. I was wondering, when you say name someone who you would want to be your medical decision maker, what does that actually mean for discrete documentation and completion of forms?
The only thing it means is that there is someone who is designated. You don't even have to list the name. It would be nice, obviously, to put that in the medical record, but that there is somebody who is designated.
And so that would be just clicking a box or saying this person has someone designated. Okay, thank you.
Yeah, great. And just
again, Jennifer, let me just clarify. If this measure were going to be used in a clinician setting, it obviously needs a little bit more work. It hasn't been specified at the clinician level. So some of those questions I'm answering in anticipation of what it would look like too.
Understood. Thank you.
Great. And we will be discussing the measure so we can talk about sort of inclusions and exclusions. It's a little premature at this juncture because we have other measures to discuss and vote. But if people have questions sort of for CMS about the status of the measure, like that's a great question to ask at this time, but we need to transition to discussing the measures that we will be voting on shortly. So Megan, with that in mind, do you have a question?
No, I was going to ask if it was going to be assessed at the clinician level in the ambulatory setting. I think a couple of things also just around age. This one, I believe, was the age was changed from 65 to 18 in the ambulatory setting. So if that's the case, if it still needs to be assessed, I'll hold my comments. So thank you.
Thank you. And Corinne.
Yeah, hi. My clarifying question. I was under the impression that there is a existing similar measure in MIPS. So to also then understand what the differences are or plans then for alignment.
So as we discuss the measure, Corinne, we'll get back to you on that one.
Okay.
In other words, if Pam Leiter's on the line, maybe you can clarify Corinne's question when we get there.
Great. Thank you all. So we're going to turn our focus to the measures we are discussing and voting today, and we can move along to the next slide. Before we get to the measure discussions, though, I just want to spend a couple of minutes briefly reviewing the primer process and setting the stage for what we're gathered here together to do today. And we can move to the next slide. So just as a reminder, the goal of the PRMR process is to build consensus to recommend measures under consideration for inclusion in CMS quality reporting and value-based programs. Our committees, which consist of interested parties, including patients, clinicians, professional societies, facility associations, and many other perspectives, evaluate measures based on whether they are meaningful, tailored to unique program and population need, balanced and scaled to meet program-specific goals, and whether they demonstrate a clear vision of near and long-term program impacts. So hopefully those bullet points sound familiar to you. They sort of match up to our evaluation criteria, which we'll talk about in a couple of minutes. So just keep that in mind, and we can move to the next slide. So the PRMR cycle essentially kicks off when the Department of Health and Human Services publishes a list of measures under consideration, the MUC list, for future federal rulemaking in December. All of the activities we undergo from that point onwards support our goal of arriving at consensus-based recommendations about MUC list measures for CMS programs. Through our evaluation criteria of meaningfulness, appropriateness of scale, and time to value realization, our committees assess if a measure is appropriate for use in the intended CMS program and target population. So you can move to the next slide. So the PRMR process can be broken down into 3 major phases, each denoted by the colored blocks in the diagram on the right side of the screen, which I understand is a little bit small to read. So we do have a link to our guidebook that we'll be putting in the chat so you can see all the detail there. In the first phase, information collection, we use available information primarily from the Merit submission tool, and we collaborate with measure submitters and stewards to develop the preliminary assessments, or PAs, which are available on our website. In the analysis and feedback phase, we collect both written public comments via our website, and we host setting-specific listening sessions to collect spoken public comment from members of the public. In a typical year, this is also when we would collect early written feedback from our committee members, what we call the pre-meeting initial evaluation, or the PI forms. This year, completion of PI forms was optional due to the delay in publication of the MUC list. We have encouraged you all as committee members to use them to help organize your thoughts about the measures according to our evaluation criteria and for note-taking, but we haven't collected them or analyzed that information systematically due to the timing of this cycle. Discussion and recommendation is the third phase, and that's what's happening today. We've gathered all of you together, including advisory group members and recommendation group members, to discuss the measures, and then the recommendation group members will be submitting votes on recommendations for the measures under consideration. Again, if you need additional detail on these steps, please do check out our guidebook. It's available online. And I did promise that we would talk about our evaluation criteria. So I'm now going to turn it over to my colleague, Dr. Lydia Stewart-Arts, to do just that.
Thank you, Meredith. If we could go to the next slide, please. I am Dr. Lydia Stewart-Arts. I lead our measure evaluation here for PRMR and MSR. Many of you who were on our committee member education call will have been familiar with these criteria and these upcoming slides, but I just want to make sure we all have a really firm baseline understanding of our evaluation criteria. So we will walk through those briefly this afternoon before we get started. Next slide, please. So when we conduct our PRMR evaluations, we have 3 guiding evaluation criteria that we ask our committee members to consider. The first of which is that of meaningfulness, and there are 2 ways to think about meaningfulness. First, we can think about it within the concept of interest, and when evaluating meaningfulness within the concept of interest, committees should evaluate whether the measure provides evidence that the measure focus is associated with a material outcome for persons or entities, and this aligns with the concept of measure importance. We ask you to consider measure components and specifications and determine if they are designed appropriately to align with the intent of the measure focus and the target population. This speaks to the concept of conformance. And then whether there are demonstration in the materials available to you that the tools, processes, and people necessary to both implement and report on the measure are reasonably available, and within the context of that specific program would reasonably be available to an average clinician, measured entity, health system, et cetera, that takes part in that quality or value-based reporting program. Next slide, please. Another way to conceptualize the meaningfulness criteria is within the context of use. So this is not program agnostic. We're asking you to look through the lens of the specific program a measure is under consideration for, and consider importance, but also think about this time a rationale for why a measure's use in the selected quality program will generate benefits that exceed costs. And when we talk about costs here, we don't just mean financial costs, we mean opportunity costs, patient burden, et cetera. We ask you to consider whether there is demonstration in the submission materials, either through data or logic, that there are known and effective ways that a person, clinician, or measured entity should use to improve on the measure focus. So could a clinician reasonably improve on this measure? Are we looking at a measure that has strong validity within the target population? Are we testing within an appropriate population to then consider a measure for a specific program? Et cetera. And then in terms of reliability, we're going to think about those effective methods we considered in the validity question, and then we're going to then look to see if there's demonstration through testing data that any changes in measure performance across these entities are due to improvements in quality of care. And then finally, for usability, we ask you to consider if there are demonstration that any barriers or facilitators that have been identified that may impact whether a clinician or measured entity, et cetera, could, in using the measure, so there are barriers or facilitators to use that have been identified, are those known and addressed? So for example, in the measure submission, if they say, hey, we think there might be some unintended consequences for this specific subpopulation, or we think rollout might be a little bit more slow in rural or low case volume facilities, for example, that would be barriers related to usability. There might also be facilitators. Certain types of health systems or measured entities might really be very quick adopters and be able to roll things out and make them very usable quickly. So all of these taken together, everything that we maybe feel a little more comfortable with, whether it's scientific acceptability, like validity and reliability, whether it's feasibility, usability, or importance, all of these sub-criteria come together to create kind of our patchwork of meaningfulness criteria. So a lot of these may feel kind of more comfortable. You may be able to speak to them more articulately based on your clinical care, but I do ask us to refrain from focusing solely on these criteria because we do in fact have 3 criteria. Meaningfulness is just one. And we also want to make sure that while endorsement of a measure based on scientific acceptability is incredibly important, and you are welcome to speak to that, ask questions about it, and even encourage additional endorsement of measures that are not endorsed, we do want to focus today on program-specific adoption and kind of usability discussions, and not re-adjudicate endorsement discussions or have a proxy for endorsement discussions. Next slide, please. Our second criteria is that of appropriateness of scale. So everything we've talked about up until this point is meaningfulness of a measure within a program. Now we're looking at kind of the appropriateness of scale and balance of a measure. So is the measure balanced and scaled to meet program target and population-specific goals? We ask you to provide an evaluation of the appropriateness of scale assertion by considering the evidence about distribution of benefits and risks or harms of measure use across subpopulations, and then also consider how risks or harms for a measure might be mitigated. So in previous years, this criteria has come up in discussions about, for example, more rare conditions being measured specifically in measured entity hospitals that might have lower case volume, or our colleagues who work in rural settings or in pediatric settings, for example. So anytime there might be distribution of benefits or harms that you think don't align with the goal of the program, the goal of the measure, we ask you to speak up from your clinical and personal experience. Next slide, please. Our third criteria really thinks about the concept of measurement and measurement consistently over time as your measure matures in the program. It's time to value realization. We want you to ask yourself, does this measure have a plan for near and long-term positive impacts on the targeted program and population as the measure matures. So we know that sometimes there may be changes to benefits or harms that may come from measuring something over time. And so we ask you to evaluate the time to value realization by considering how harms and benefits may change over time as the measure matures in a program. And then also consider ways in which the benefits of a measure might be prolonged or how potential harms could be prevented. Next slide, please. Okay, we provided you with preliminary assessments. They included descriptive information about measure specification, endorsement, and prior historical CMS use. Our CMS colleagues provided individualized rationale for measure inclusion based on the CMS programs. And then we also included any considerations for statutorily required areas and upcoming rulemaking. So for example, if a measure fills a topic area that is statutorily required by for the program, we let you know in the preliminary assessment. Next slide, please. In order to develop these preliminary assessments, we used as our first source of truth content submitted by the measure developers through CMS Merit. And thank you to all of our measure developers who were on the call. They have been in tight collaboration with us throughout this process, and I truly appreciate all of your work helping us get to today's point. We also looked at historical information for endorsement and maintenance review using our own PQM STAR database. We looked at results from measure testing and where possible, tried to create comparable decile tables for reliability across measures. We weren't able to do that for every measure, but we did want to ensure that our individuals who maybe don't have as heavy of a statistical background could still find the information accessible. So we hope that that was helpful to you. We included findings from scientific literature and, where possible, learnings from conversations with measure developers or stewards and CMS. So for example, if additional testing happened after the submission deadline, while we technically weren't allowed to include that submission, we didn't include a note for the committee members or discussion questions for committee members that kind of let you know there was additional work going on and kind of ask them additional guiding questions. So we really tried to help every measure put their best foot forward this year in the preliminary assessments. Next slide, please. And with that, I will turn that over to my colleague, Kate Buchanan. Thank you so much.
Thanks so much, Lydia. I appreciate it. So now we're going to go through the primer voting process. And we are going to do voting a little differently this year in that we are going to open voting for a minute to collect the votes. And then recommendation group members may continue to vote. We'll leave it open as we go on to the next measure. We will use this time to track down any asynchronous votes we need to get. I know that a couple of people have said that they are stepping away at certain points. So we will be reaching out to them about their votes. And so we will be presenting the votes at the end of the day on a slide. And if we do not get if we do not get voting quorum for one of the measures, we will do outreach after, and we will send those voting slides to the committee members as a follow-up communication. Next slide. We are working with our fantastic co-chairs to kind of establish ground rules, make sure that not one voice is dominating the conversation, get to a point where we feel comfortable with there's some kind of consensus on moving forward to a vote. We'll be using Poll Everywhere to vote. And as with previous years, our consensus threshold is 75% agreement among the members. Next slide. So everyone should have received a voting link. It was sent at, I think, 11:31 a.m. Eastern time today. If you did not get it, please message us in the chat and we'll get you connected. And then we can move on to the next slide. We have two quorums that we have to pay attention to, one of which is discussion quorum. That's at least 60% of recommendation group members present at roll call at the beginning of the meeting. We have that, so thank you all very much. And then this is where it becomes incredibly important for voting quorum. We need to have at least 80% of active recommendation group members who have not been recused from a measure available to vote in order to have voting quorum and share the results. If for any reason you need to step out, we really, really ask that you message us when you are leaving, your anticipated return, and your vote if you will be missing a vote time. And so this is our plea for you to please let us know if you have to step out, because we understand many of you are clinicians and have incredibly important things that may come up. Just let us know. Thank you. Okay, next slide. So speaking of quorums, what are our quorum numbers? We have 30 active clinician recommendation group members. We need 18 of you online to have discussion. We need 24 in order to receive voting quorum and have official voting results. Next slide. Voting is a little different this year than it has been in past years, and we talked about this during the education meeting, but I do want to reiterate it. So you can either vote to recommend or not recommend. In years past, we've done a recommend with conditions. The intent behind that was that there was going to be a measure that you would say could be used in program, but the developer needs to change something that was in their control in order to do that. And so we found, though, in practice, people kind of used it as a feeling, a mediocre feeling about a measure. And so what we are doing instead is that you can either recommend, and you may provide considerations to CMS to review prior to the implementation, and you'll do that in the chat. Or do not recommend, and you have to present rationale to describe a vote not to recommend, and that will be within the Poll Everywhere platform. Next slide. And so here, this is a chart we also shared during the education meeting, but here you can see the voting results and how they are reported. So as we noted, you have two choices: recommend, do not recommend. And for do not recommend, you have to provide rationale. For recommend, you can provide conditions, and those conditions will be provided in the chat. We have our same consensus threshold, so 75% or greater. If 75% or greater of the committee members recommend a measure, then it is recommended for the program. If they 75% or greater do not recommend a measure, it is not recommended. Here is where there's a little bit of a difference, and this is trying to get at some of the nuance of discussion. If committee members, if there is agreement, 60 to 74% committee members, one way or the other, we report that as, although consensus was not reached, the majority of committee members expressed either support or some concern, depending on whether or not it's an affirmative or a do not recommend, for use of the measure in the CMS programs. And then for 41 to 59%, the committee did not reach agreement. And if there are any clarification we can provide, please feel free to ask questions in chat. But that is our voting for right now. So I'm going to turn it to, I believe, my colleague Elena to go through a voting example.
Kate, I'll be handling that.
Oh, great.
Good afternoon, everyone. As Kate mentioned earlier, around 11:30 a.m. Eastern today, we sent an email containing the voting link to committee members of the recommendation group. So please take a moment to look for an email from pqm@battelle.org with the subject line containing the phrase voting instructions. If you can't find it, let us know via chat and we will send the link to you in the chat. And as a reminder, this link is exclusively for the committee members of the recommendation group. So please refrain from sharing the link with anyone. Throughout today's meeting, please keep the voting window open. Once you access the voting link, you will be prompted to enter your name. Please ensure you enter your first and last name and click continue. Once you enter your name, you will see your full name and initials in the top right corner of the voting screen. If you missed a pop-up to enter your name, click the icon in the top right corner to change your name if you are assigned a randomly generated name. If you close the voting window, you will need to click the voting link again and add your name. After entering your name, your screen will display waiting for PQM's presentation to begin. Next slide. Once voting opens, the multiple choice question and answer options will appear. The first tab displays the measure. The second tab with the pin icon is for entering a rationale only if you vote not to recommend a measure. Next slide. To provide a rationale, click the tab with the pin icon. Type your brief explanation and click submit. please do not use the thumbs up or thumbs down feature. Your provided rationale will be anonymous. However, all voting members, regardless of their selected voting decision, will be able to see the anonymized rationales in real time. If at any point in time you encounter challenges with the voting platform, you may send your vote directly to me in the Zoom chat. With that covered, we can go ahead and test the voting platform. All right, today's test vote is, do you agree that the best way to enjoy a cookie is crumbled on top of ice cream? If you agree, select A. If you disagree, go ahead and select B. And if you do select B, you are required to provide a rationale in the next tab. If this were to be a measure, you would be required to provide a rationale specifically if you vote for B to not recommend a measure. And I believe we are expecting 27 votes. And we have all 27 votes. All right, we can go ahead and share the results. So with voting closed, we have 12 votes agreeing that this is peak dessert engineering and 15 votes disagreeing. And for some of the rationales, we have people saying cookies are their own thing. They don't need anything else. Someone says cookies should be enjoyed independent of ice cream. Okay, so we have people agreeing that cookies should be a standalone item. A lot of people agreeing that cookies are a standalone item. So, all right. With that covered, I will turn it over to Meredith Eastman.
Thank you so much, Isaac, and thank you everyone for entering your votes. Who knew that cookies could be so polarizing? So thanks for making sure we could collect all your votes today. So before we get into the measure-specific discussions, I did want to just provide an overview of some information we'll be providing about each measure, and we can move to the next slide. So I'm specifically going to talk about the public comments received and also findings of a literature review that Battelle conducted on closing gaps of care. So we can move to the next slide. So as I mentioned when I gave that very brief overview of the primer process, we do host a public comment period, a written public comment period on our website to collect feedback from the public on the muck list measures. This year, our public comment period extended from December 16th through January 6th, and we received a total of 600 public comments across the 24 measures that are on the 2025 muck list. We can move to the next slide. Specific to the clinician level measures, we received 159 written public comments, and we received 10 spoken public comments at the listening session that we held on January 7th for a total of 169 comments on clinician measures. We will be posting in the chat, if it's not already there, a compilation of these public comments from our posting on our website on Monday. As we go through measures, the Battelle facilitators will be summarizing kind of the key themes of comments in support and of concern for each measure prior to turning to the committee for discussion. And we can move to the next slide. So Battelle also conducted a search of peer-reviewed literature and federal agency websites to identify how measure topics and conditions might differ according to factors including age, geography, dual Medicare Medicaid eligibility, insurance status, and language and literacy. Battelle facilitators will also summarize these findings for each measure prior to turning to the committee for discussion. It's important to note that closing gaps of care is not a primer evaluation criterion, but we do provide these findings to the committee as they reflect on how each measure, through use in a Medicare quality program, may contribute to closing or widening gaps of care for various population groups. And as we turn to the first measure, We can move to the next slide. I did just want to briefly review how the measure discussion will proceed. We did discuss this at the education meeting, but just as a reminder, how the discussion will flow. Battelle facilitators will review a measure overview slide that has the measure description and some key characteristics. Then we will turn it to a CMS medical officer to provide the rationale for including the measure on the MUC list. Battelle's staff will then summarize public comment and closing gaps of care findings, and then we'll turn to the advisory group first. We want to hear from you what you think the priority discussion topics are for the measure. What do you think the recommendation group should really dig into and consider in their vote? Then we'll turn to our patient participants to share their perspectives on the measure. And then lastly, we'll open it up to all the advisory group members. Having heard from the advisory group and the patients on what the priorities for discussion are, we'll continue to discuss and delve into the topics that have been identified as priorities. And then when we feel like we've reached a saturation point on the conversation, we'll confer with our co-chairs and we'll move to a vote. So there is a cheat sheet for this flow in the chat for your reference. So please take a look if you need a reminder. And now I think we are set to begin our first measure discussion. So our first measure today is low density lipoprotein. Sorry, I just got to move something out of the way of my screen. Thank you. Lipoprotein cholesterol monitoring and management. This is the percentage of patients aged 18 years and older with clinical atherosclerotic cardiovascular disease, or ASCVD, who received a low-density lipoprotein cholesterol test, the CDLC test, via lipid panel and achieved an LDLC of less than 70 milligrams per deciliter on the most recent test during the measurement period. This measure is stewarded by the American Heart Association. It is being considered for use in MIPS. It is also an outcome measure at the individual and group level of analysis, and it is not endorsed and has not yet been submitted for endorsement. So with that brief overview of the measure, I'll turn it over to Dr. Stephanie Clark at CMS.
Meredith, this is Dan Green.
Oh.
I think I'm taking this one.
Okay, over to you, Dr. Green. Apologies.
No worries. Thank you. Good afternoon, everyone. My name is Dan Green. I spoke with many of you this morning on the roundtable and even yesterday with some of you on the hospital side. I'm a medical officer here at CMS working under Drs. Michelle Schreiber and Ron Klein. I am an OBGYN by training. And I'm going to try to be really brief with this LDLC measure because we did have a very thoughtful and lengthy discussion about it this morning, but obviously there may be some new folks on the call that want to provide input, which of course is welcome. So this LDLC measure basically has two numerators. One is percentage of patients who are tested, and then the second numerator looks actually at whether or not patients with a history of clinical atherosclerotic heart disease has achieved an LDLC of less than 70 milligrams per deciliter. We're kind of excited about this measure in as much as it's an outcome measure. So we're actually looking for patients being managed to the current recommended goal for their LDLC. Again, it is an outcome measure. It does align with our Meaningful Measure 2.0 framework, and it does fit in the healthcare priority of chronic conditions. It has the potential to be included in a primary care MVP. There is a gap. The numerator 1, which was just the testing, has an average of about 65%, whereas the second numerator is about 47%. We do have a measure in the MIPS program currently, which looks at use of statins for at-risk individuals, and those are currently defined as patients who have a diagnosis of clinical atherosclerotic disease, patients who have diabetes and are between 40 and 70, patients who are 40 and 75, patients who are 40 to 75 with a 10-year ASCVD risk score of more than 20%, or patients who are 20 to 75 who have ever had an LDL-C of over 190. Now, again, the difference between the two measures, the measure I just mentioned with the four different criteria for inclusion, basically did you put the patient on a statin? Did you attempt to treat them? This is actually looking for a treatment goal. So again, this is an outcome measure, and to that end, we're kind of excited about it. Meredith, I'm not sure if I'm back to you or Kate, so.
Yeah, I will take the ball. Thank you.
Thank you.
I'm going to just briefly summarize some themes from public comments that we received. We received 26 written public comments on this measure, including comments from pharmaceutical companies, professional societies and associations, and including one letter of support from a member of the U.S. House of Representatives. And we received 2 spoken public comments at the listening session previously. So just in terms of support, public comments noted that there's irrefutable evidence that lowering LDL-C leads to a proportional decrease in ASCVD risk, and that LDL-C is reliable and well established as a biomarker. They've noted a reversal in ASCVD trends since 2025, with age-adjusted mortality rates increasing after more than 50 years of decline, which does indicate an important improvement gap to address through this measure. Other comments noted that the majority of ASCVD patients have uncontrolled LDL-C and require additional clinical support in achieving targets. And that the adult ASCVD population is clinically complex, with a substantial proportion experiencing multiple chronic conditions. And all of this, significantly increases cardiovascular risk and underscores the importance of LDL-C monitoring and management. Some commenters noted that this measure is particularly relevant for individuals with chronic kidney disease, with ASCVD being a leading cause of mortality in people with CKD. And this measure does align with guidelines put forth by the Kidney Disease Improving Global Outcomes, and that it encourages LDL-C monitoring and management. Furthermore, commenters noted that this measure aligns with the guidelines from the American Heart Association and the American College of Cardiology in setting an LDL-C goal of less than 70 milligrams per deciliter for ASCVD patients. Other commenters noted that the current quality measures for cholesterol, as we've said, currently only assess whether a statin has been prescribed rather than whether treatment is effective in lowering LDL-C. And so this measure really, as Dr. Green was mentioning, helps bridge that gap to measuring outcomes. Furthermore, comments indicated that for patients, LDL-C is a clear, actionable metric. There were some concerns among the public comments. One comment recommended consideration of risk-based stratification for the very high-risk clinical ASCVD population, and with an LDL-C target of less than 55 milligrams per deciliter. Another comment from the American College of Cardiology suggested that the measure should allow for appropriate exceptions in patients with multimorbidity and should recognize shared decision-making. They suggested that LDL-C monitoring and LDL-C goal attainment are different constructs and perhaps should be reported separately to preserve interpretability. They noted that the score may be biased by lack of data availability in multi-payer or community settings with limited lab integration, and specifications should guard against this potential. They suggested allowing a 50% reduction in LDL-C as an acceptable alternative for patients without a baseline value, and they encouraged subgroup monitoring to avoid exacerbating known disparities in LDL-C testing and control among women and racial and ethnic minority populations. I will note that one comment from the American Geriatric Society expressed concern about measure feasibility, and they recommended improving the specifications from a feasibility angle prior to implementing in MIPS. So that's sort of the gist of the public comments we received, and we can move along to the next slide. So our closing gaps of care literature review found that older adults often have difficulty controlling LDL-C levels, likely due to factors such as multimorbidity, frailty, cognitive impairment, and taking multiple medications at once. Patients seen at practices in urban locations are more likely to undergo lipid testing than at practices in rural locations. While insured and uninsured individuals have similar rates of hypertension and elevated LDL cholesterol, uninsured individuals are less likely to receive treatment and achieve control of these conditions. And lastly, with regard to language and literacy, many participants lack detailed knowledge of their specific target values and rely on lab results for interpretation, with one study finding that 1 in 3 participants did not fully understand how serious high cholesterol was after being diagnosed. So with that overview of the literature, the measure description, comments from Dr. Green, I think we're ready to turn things over to the advisory group members to kick off the discussion. We'd love to hear from you if you're on the advisory group about what are the key critical issues you want to be discussed about this measure. Where would you like to see the recommendation group take this discussion today? So I invite you to please raise your hand. You have thoughts. Great. Paulo, you're up first.
So Dr. Green did a great comment this morning saying that doctors are perfectionists and they want to reach 100% on every possible quality measure out there. But that can cause 2 risks. That one to the patient. The second risk is that with time, the measure will need a more complex logic to include exclusions, and we keep adding them. And that makes developing software and tracking measure much more complicated. So I suggest that I support the measure, but when it's implemented at CMS, consider giving a target that you can reach 10 MIPS points with a 90% or something lower than 100%, like they did with the A1C control, where CMS says you cannot reach 100% control on A1C. That's not recommended. If you can reach 90%, we are happy with that, so we don't go in this race to try to reach 100% and can cause clinical damage. And you don't want to be over prescriptive, that you create every possible exception and exclusion that you write on the rules, and then you keep adding more and more every year and makes it so complicated that nobody can calculate it and the physician is lost.
Thank you. So Tom, you are up next.
Yes, thank you. I have to agree with Paulo. He basically covered everything I would say. I think we need to focus on the gaps, the age problem, the comorbidity problem, the medicine burden, and the shared decision-making process to ensure that patients are fully on board and aware of what's going to happen so they can carry this forward. Thank you.
Great, thank you. Any other advisory group members want to chime in and set the direction for this discussion? Yes, Matthew.
Hi, not too much more to add, but I would definitely say I do think some advantages of this measure, especially as we compare it, as was mentioned previously, to existing measures in the same realm, are really, I do personally like the fact that it seems to accommodate beyond just the statin therapy. So in other words, by having a target like this, instead of the target being was a statin dispensed, I feel like one advantage is that does open up the possibility for incorporating other additional interventions, like lifestyle, exercise, diet, especially for those members that a statin just cannot be tolerated. We know that we see quite a bit of that just in the existing measure, as well as some limitations in the data access to the claims that tie back to that statin being dispensed. And then, of course, a big limitation of the existing measure is obviously, yes, the statin was dispensed, but there's no additional follow-up to confirm how it's being taken, if the member is being adherent to it. So I do think this has a stronger target to the ultimate end goal of controlling the LDL.
Great comments in support of this measure generally. I do see a comment from Heather in the chat supporting this measure from an advocacy perspective because it encourages prevention and ongoing management. And then she notes it's also critically important to account for access and barriers to the medications, labs, follow-up, care, et cetera. So I think that's an important thing for us to keep in mind as well. I do see a question in the chat about specifications from Jennifer Woodward, who's on the recommendation group. I wonder if Dr. Green, if CMS or the developer would be able to respond to that question about capturing exceptions in the chat.
Yeah, that'd be great if AHA could take that.
Excellent. So we thank you, Amy, for addressing that question. And let's go ahead and I think we've already heard from some patients already, but let's see if our patient participants, anyone who hasn't yet had a chance to speak, would like to weigh in on this measure. Reggie, yes.
I am excited about this measure as a patient that has chronic condition and a diabetic. I know how important cholesterol numbers are to myself. The fact that I live in a suburban area, it helps tracking. I guess my question would be, people that live in rural communities, are they going to be able to get the data in a timely manner?
Great. Thanks so much, Reggie. You faded out a bit at the end, but I think we caught that, you're concerned about the rural communities being able to report on this measure.
Correct.
Got it. Thank you. Any other of our patient committee members who wanted a chance to weigh in? Okay. So we've heard, largely support about this measure from the advisory group members to our patient committee members. Before we open it up fully to the recommendation group, I did want to note, I think we've had a couple of folks join us since we did roll call. So I just wanted to see if we could get a couple of quick disclosures of any conflicts of interest. Ramsey Abdullah, are you able to unmute and indicate if you have any conflicts of interest to disclose?
Hi, this is Ramsey Abdullah. I have no conflicts to disclose. Thank you.
Super. Thanks so much for that.
You're on mute.
I'm on mute. We can go ahead and open it up to our recommendation group members. So I know we've had some questions about specifications in the chat. If the recommendation group wanted to weigh in on what they've heard thus far from the advisory group, any concerns about this measure they wanted to raise? Yes, Jennifer Woodward.
Thank you very much. I have a couple of questions which would be helpful to know answers to before voting. Many primary care practices have other care team members integrated into the patient's care team, and sometimes these exceptions are only able to be the code to be dropped with an office visit. Some of the other care team member visits are not billed and therefore don't always generate a CPT code. So just wondering how other healthcare team members could assist with the documentation of patient exceptions. And then one other point that I would like to make is that I see, I think I see it. My concern was that I see pregnancy as an exception, but I did not see the patient is planning to become pregnant or could become pregnant, but I see that that's allowed as a medical reason exception. So I think that I have answered my own question. So thank you very much.
Okay, great. Let's move along to Tipu.
Yeah, thanks. A few comments. And even this morning, there was a lot of discussion about earlier interventions along the lines of primary prevention. And really, the LDL-C goal of less than 70 has been published in the literature in patients that have already been diagnosed or had an event. And expanding that to a much broader population, I think, raises the concerns about some of the long-term side effects of the drugs used to lower LDL, and some of people have commented on those in the chat, including concerns about increasing the risk of developing diabetes, as well as longevity and memory issues. So it's a completely different discussion to think about this as a goal for primary prevention. In terms of the goal for secondary prevention, the data's for achieving a goal of less than 70 is pretty impressive. Less than 10% of the population can achieve that goal with diet and exercise and lifestyle modifications. Most people are going to need drugs to do this. Statins are the primary drug, but to achieve a goal of 70, many patients need more than one drug, and some of these drugs are really expensive, and I'm concerned about the cost of these drugs and access to these drugs. I could see expansion of the statin measure to include whether a more comprehensive treatment plan for lowering LDL is in place, but to actually put a number on it, and again, I think is concerning without addressing some of the issues of access to these drugs.
Okay, thank you for those thoughts about the potential implications for expanded use of statins and the relationship of this measure to primary versus secondary prevention. Jeff.
Yes, thank you. We've discussed this in the earlier conversation, but a couple of points. One, I really think that this should be evaluated at a system rather than the individual clinician level. It is very common that there will be a cardiologist, a primary care physician, maybe a dietitian, and others involved in care, and that we should move away from this sort of individual clinician accountability to a broader perspective. So inclusion in things like MIPS, while obviously people can choose, it I think sets the wrong direction for us. The other issue is around the cost, which was just raised, to get patients to 70 who are at the highest risk of recurrent events is often impossible and very cumbersome in Medicare currently to use drugs beyond the typical statins. And then finally, I actually think there's potentially more bang for the buck at looking at primary prevention in those individuals at high risk. I'm wondering why this doesn't parallel the statin use measure and left off those, for example, who have type 1 diabetes. Thanks.
Great, thanks. And I know that we have a couple of questions in there, so I'm going to, I guess, see if CMS or the developer would like to respond to any questions or thoughts that have come up in this discussion thus far.
We would love for Dr. Shaw to respond first for the association.
Okay.
Hey, thank you so much. I hope you guys can all hear me okay. Great discussions in the chat, and we certainly appreciate all the support. for this measure that we've gotten so far through some of the public commenting and discussion that we're actually having here. Just as an introduction, my name is Nishant Shah. I'm a preventive cardiologist and clinical research at Duke University, and I'm also assisting the AHA in the development and presentation of this measure and representing the AHA here on this call. A lot of great points were raised, and in my world of preventive cardiology, where I lose sleep at night is that someone is dying of cardiovascular disease every 34 seconds. 4 million people across the world are dying from cardiovascular disease attributed to elevated LDL. And as you guys have all very nicely noted, in our world, even patients with atherosclerotic cardiovascular disease, many of them have uncontrolled LDL years even after their event, and many of them aren't even on a statin, despite there already being a quality measure supporting a statin. So looking at the totality of the evidence to address the question about why not expand beyond just ASCVD, which as a preventive cardiologist, I completely agree. And in my clinical practice, I have those shared decisions with patients to individualize risk and get to an LDL goal that is appropriate for that particular patient. But considering that the vast majority of patients out there with ASCVD don't have LDL controlled. In some US cohorts, 50 to 70% of patients with ASCVD have uncontrolled LDL. The rationale behind focusing on just ASCVD population was to go where the evidence is the strongest and most robust to create a foundation addressing the highest risk patients. Because currently what we have, a measure of just being on a statin alone, comes with a lot of issues, as everyone nicely noted. There's truly cannot tolerate them, even though they're readily cheap and accessible therapies. A statin may just not be enough. Some people may need alternatives. And also what a statin may not drop someone's LDL goal low enough for that particular person. And so the idea was first to create a measure around where the evidence is the most robust and hopefully build a foundation where we then can have discussions about expanding recommendations for targeting particular LDL-C goals across different populations. But also, I just want to add to the point that by having a particular goal, that'll also foster LDL-C testing. That is also a gap in care that we're seeing where LDL-C is not even being tested routinely, even after people within 3 months of a cardiovascular event. And there's huge gaps, which have been nicely noted in some of the public commenting, in older individuals, rural dwelling individuals, women, underrepresented minorities, and many with various other comorbidities. And so we really want to, emphasize something that is easily identifiable, having diagnosis of ASCVD, a goal that fosters testing, and hopefully allows for, a foundation to build from. I hope that answers some of the questions in chat.
Thank you so much for that additional context and the rationale for focusing on the patient population you have.
Hey, Meredith,
Yes.
excuse me. Thank you, Dr. Shah. I just want to hit one comment in the chat. So there was a comment that as we move MIPS to MVPs, this particular measure, if it were adopted, would likely be in an MVP. That's true. But within MVP, there still is clinician choice as to which measures they report. Many of the MVPs have 6 or more measures. Some have up to a dozen or so measures. So they're still at this point is clinician choice in terms of which measures under an MVP they choose to report. And that's currently if they choose to report an MVP, but we are moving in that direction of MVPs, just not necessarily all the measures being mandatory in a particular MVP.
Great. Thank you for that clarification. I know that was a question that had come up in the chat. So we've heard a lot about kind of the benefits of this measure, the rationale for focusing on the ASCVD population, that it's measuring an outcome with a lot of evidence behind it. But on the other hand, we've heard some concerns about, medications, availability and access to those medications and costs with those medications and how that plays into performance on this measure. So I just encourage the recommendation group to really weigh those two sides? Like, do the risks outweigh the benefits, or vice versa? And I did want to check in with my co-chairs, Deepak and Krista. Do you feel like we're ready to vote on this, or do you feel like there's more to unpack here, or anything you would like to add?
No, I think that was a great discussion. I did note, I think Corin Rubin mentioned that it depends upon the MVP, and some MVPs you don't have a choice because of issues with scoring. So noting that, I think the general concerns that are there. So a lot of good discussions, and also confirming and echoing the comments from Dr. Corey. So I wonder if we just want to look at the last question, or Wai Ying, if you want to unmute yourself regarding the endorsement, but it was regarding CBE endorsement and considering a strong indication of reliability with that. So well, it's a question about weighing in with regard to CBE endorsement and what that issue might be.
Yeah, that's exactly what I was asking for. I know years ago, CBE endorsement was pretty much an assurance of the statistical experts or statisticians or measure developers expert has looked at the measure and give us a stamp of approval regarding the validity and reliability. I definitely have seen the relevant information in the package prepared prior to the meeting, but just want to pose a question here since this come up again that some of the new measures without CBE endorsement, that should we treat it or let's say another measure does have CBE endorsement, it is one better than the other, or this is more just FYI, it doesn't carry much of the weight anymore these days?
So I think what we don't want to do is have a proxy discussion for CB endorsement. It is a separate process, as you noted, and it may or may not happen prior to, being implemented in a CMS program. I don't know if Dr. Green or others at CMS wanted to weigh in on sort of the intention of putting this one through endorsement, but we do have the information that was submitted in the merit tool, and we've provided that. So I would ask the committee to use that those test results in weighing this measure's readiness for implementation.
I mean, Meredith, I would just think that if a measure is submitted for endorsement and rejected, that, could be telling, not always. Sometimes there's just, more testing that needs to be done or what have you. But if it's not been submitted, I don't think we can draw any conclusions.
Right.
As you know, it's a time-consuming and costly process.
Exactly. Okay. So let me check back with Krista and Deepak. You feel like we're ready to move to a vote?
I think that would be reasonable. I will just note Dr. Corey's last comment regarding supporting or favoring expanding the stat measure to include a more comprehensive lipid management treatment. I think it's more of a comment unless you wanted to add anything else, Dr. Corey, but otherwise I think we should be ready to move to a vote.
No, nothing else to add. Thank you.
Krista, are you in agreement?
I am in agreement.
Super. So I'm going to turn it to Isaac, and we'll collect votes.
Thanks, Meredith. The question should be up in just a second. Voting is now open for MARC 2025-34, low density lipoprotein cholesterol monitoring and management. Do you recommend including this measure in the merits-based incentive payment system? The options are A, recommend, or B, do not recommend. And if you're voting to not recommend the measure, please provide a rationale in the next tab. And we are expecting 27 votes.
Sorry,
We have
Isaac, if
20
the
votes in so far.
working, sorry, that if the link is no longer working in the poll, do you want us to just put it on Zoom or?
Yes, if you're having trouble, send it directly to me in the chat. Send your vote directly to me, and if you're voting for B, also include your rationale. We have 24 votes in. All right, we have all 27 votes. I'll turn it over to you, Meredith.
Great. Congratulations, everybody, on the first vote. So we completed our first discussion, and I think we can move along to our next measure.
Yep, this one's on me. Hi, everybody. I just want to note we have ourselves scheduled to try to get through. There are 3 measures that we want to try to get through within the next hour, which is a little bit ambitious. We may end up just shortening the advanced care planning conversation since that one's not leading to a vote. But either way, I just want to emphasize to everyone the importance of conciseness in your comments, especially if you're saying something that is in agreement with something that another person said. Please take advantage of the chat for that to note any instances where you're agreeing with something somebody else says so that we're not retreading the same ground and using up time that could be used for additional perspectives. And with that, I'm going to take us to the rate of timely follow-up on abnormal screening mammograms for breast cancer detection, which is MUC 2025-042. Go to the next slide. Okay, so this is an ECQM that reports the percentage of female patients aged 40 to 75 years with at least one abnormal screening or screening to diagnostic mammogram during the measurement period, which is a calendar year. Who received timely diagnostic resolution defined as either follow-up imaging with negative, benign, or probably benign results, or a breast biopsy within 60 days after their first abnormal screening mammogram. This was stewarded by Brigham and Women's Hospital. It is a process measure at the clinician and facility level of analysis, and it was endorsed with conditions during the spring 2024 cycle. So I want to turn it to, I think this one's going to be Dan again, to talk through the CMS rationale.
Yep, you're stuck with me for the next 2. Hi, everybody again. Thank you, Brenna. So this is an ECQM, so electronically specified clinical quality measure, looking at the timely follow-up of abnormal screening mammograms for breast cancer detection. There currently are no other related measures that look at timely follow-up for abnormal mammograms. So this does drive the quality of patient care through promotion of early detection for breast cancer. The measure is fully tested and developed. It aligns with CMS's Meaningful Measures 2.0 framework. And it does fit into the healthcare priority of wellness and prevention. This measure could be considered to be included in the diagnostic radiology MVP. The performance range is 70 to 98%, depending on the groups or locations. Again, it looks that the follow-up testing was done within 60 days. And if anyone's ever had an abnormal test, particularly, a mammogram, especially those of you that are primary care on the phone or on the meeting, it's extremely worrisome for the patient. And 2 months is, we think, still is a long time. We think it should be less time, we being CMS. But certainly having to wait more than 2 months to get in and to get either a biopsy or follow-up testing is a long time for a patient to have that increased level of anxiety, fearing that they have cancer. Probably one of the most concerning things, in fact, especially for our female patients. So just want to make that note. I'm sure everybody's aware of that, but sometimes we don't talk about it. So Brenna, I'm going to send it back to you. Thank you.
You. So I want to just review some of the public comments that we got on this measure. There were 11. In support of this measure, we heard that it has the potential to enhance the quality of care in breast cancer, given that it's the second most common cause of cancer deaths among women in the United States. Research has really highlighted the importance of timely follow-up care after receiving abnormal screening mammograms, and it's known that delays can lead to further progression of the disease and worsened outcomes. That same comment cited a few other studies, again, aligning with the intent of the measure and expressing support. And another commenter also said this quality measure can be used to address quality gaps by monitoring timeliness and completeness of care to improve breast cancer screening and diagnostic processes. And we received that feedback from several different commenters. On the concern side, as Corinne pointed out in the chat, we did receive, the criticism or the feedback that although this measure is endorsed, the testing that was used for that measure at the time was not at the clinician level. So there's maybe some additional analysis that needs to be done. And we heard from the American College of Radiology that while they very much appreciate CMS's efforts to improve timely follow-up care, they do have some concerns about applying this measure at the clinician level. They saw that the measure had been retested at clinician level, but still felt like it was insufficient. And their reasoning was that this measure has very, very high stakes for radiologists. As Dr. Green mentioned, this measure would be the only breast cancer imaging measure in MIPS, of making accuracy and feasibility really critical, because any errors in data capture or reporting could disproportionately affect radiologists' MIPS scores, and of course their payment adjustments accordingly. They did express some concerns around technical feasibility because imaging reports, including BI-RADS results, are often stored in unstructured EHR fields, which require some complex extraction. And then again, just some worries about accountability, that radiologists would be penalized for delays that are outside of their control, things like scheduling bottlenecks, patient navigation issues, and other patient-driven delays. And then just the resource burden, especially in smaller rural facilities, in terms of the dedicated IT resources needed. So I think that pretty much sums it up. I think broadly high levels of agreement that breast cancer is a massively important topic, and that this measure could be really beneficial towards moving the needle to improved follow-up for abnormal screenings, but also just recognizing some feasibility concerns on the radiologist side. Let's just pop to the next slide so that we can look at the closing care gaps considerations. So when we think about age, we know that delayed follow-up after an abnormal screening mammogram was associated with folks of older age, particularly in individuals over 70 years of age. We know that women in rural areas experience higher false positive rates on diagnostic mammography, delays in biopsy, lower access to core needle biopsy, and impaired access to treatments, which maybe speaks to some of the challenges we heard in public comment. In terms of insurance status, we know that patients who are on Medicaid or who have no insurance are more likely to delay breast imaging care due to out-of-pocket costs compared with patients with insurance through their employer. And then finally, in terms of language, non-English speaking Latina patients experience a 5 to 6 month longer overall care path compared to English speaking Latina and white patients, with the greatest delays occurring from initial findings to diagnostic mammogram, and then from biopsy to surgical resection. Okay, let's pop back to the description slide, and I want to open this to our advisory group members, just to float up any topics that you want to make sure that we center our discussion on. Already seeing some back and forth in the chat for recommendation group. Yeah, David.
Yeah, hi. So my name is David Seidenworm. I'm a radiologist, a neuroradiologist, but I read mammograms at an MQSA minimum level for about 20 years. I just want to point out that the MQSA, the Mammography Quality Standards Act requirements for volume are, I think it's 240 every 6 months, so 480 a year. So the reliability at the individual radiologist level should be pretty good, at least as good or better than for other clinical metrics that are out there. Though, having said that, it's of course even more reliable at the TIN or group level.
Thanks for that, David. All right,
Oh, should I disclose conflict of interest? I have some conflicts of interest with regard to prior breast imaging metrics.
Please do. Okay, I'm seeing lots in the chat here, so why don't I just open it first to our patient participants? I'd love to hear from you about this measure and your experiences with the healthcare system. Yeah, Reggie.
Yes, I'm also reading the information in the chat, and I appreciate everyone's feedback on this. On the surface, I do support the timeline. I just as Ms. Daniel said, 60 days to get abnormal screening, I think is a long time, really. And I can see that working in the suburban areas. But on the clinician level, and also outside the suburban areas, that may be a challenge. But on its face, I see the value of it. I would like to hear more data or some more pushback on the 60 days from anyone that has value information on it. That's all I have.
Thanks, Reggie. All right, and not seeing any other hands from our patient participants, let's just open this up all the way to the recommendation group. Yeah, Richard.
Thank you very much. So in the spirit of disclosure, I am a radiologist. I am a member of the American College of Radiology, and I do work with some of their committees on this, but I was not involved in the analysis of this measure or the drafting of their letter. And I also would add that I agree with the intent of the measure, but I echo the comments that were made in the American College of Radiology letter. And if you haven't, I appreciate that you summarized it. I would argue they were a little bit stronger than maybe what you implied, though. I think there were substantial concerns with the measure at the clinician level. I think we agree with the systems level, but the concerns about the clinician level and the fact that it would have as you used and as they mentioned in the letter, it's a high stakes issue because it would be the only breast measure. The fact that many of the aspects of it are outside of the radiologist's control, I think is concerning. And I think more testing would be valuable. So I echo the comments from the ACR letter and appreciate it. Thank you.
Yeah, thank you for adding the extra context and apologies. I didn't mean to understate the concerns.
No, you did not at all. I just wanted to make sure that people were clear that like it was there were meaningful concerns, but I appreciate your comments.
Mm-hmm. Jeff, go ahead.
Thank you. I'll just chime in that I think the attribution issue makes this measure dead on arrival. I believe that this is a system-based issue. I've dealt with this extensively in a large health system, and the issues were not at the clinician level primarily. I mean, there occasionally are, but it was primarily around how many mammography techs, how many units, what were the communication and coordination issues, and are there resources to adjudicate abnormal mammograms? So I do not support this going forward or being recommended because of that.
Thanks, Jeff. That's important context and a valuable perspective. Christine.
Yeah, I was just wondering about the lower age range and whether it was necessary. So if mammogram is indicated for you because of a family history, we would still want to see the follow-up, right?
I think that's a question for CMS. So Dr. Green, did you want to take that?
I would love to, but I didn't quite understand, Christine. I apologize.
The lower age range of 40, I would think if it's a mammogram is indicated for you because of family history, we would still want to see the follow-up.
Well, the lower age of 40 is consistent with American College of OBGYN's recommendation in terms of starting. There are other organizations that also recommend age 40. So I believe that's, but I have to defer to Brigham as to specifically why they selected that. Patients that have increased risk for breast cancer, and there, as you well know, probably are different risk calculators that can be used. Quite honestly, some of those folks are actually recommended to start mammography screening as early as 30, and even MRIs as early as 25, depending on their genetic status. So I think the age is kind of all over the place, depending on the patient's personal history. But again, with the organizations recommending screening mammograms, start after discussion with your patient at age 40. I think that's probably why Brigham picked that particular age. And I hope that answers your question. Maybe not.
No, it did. Thank you.
Thank you so much.
Right. I'm seeing, hang on one second, Dr. Klein, I see your hand. I just wanted to check the chat because there's quite a bit happening over there. And I want to make sure that if there's anything that needs to get raised up, that it does. Yeah, so I'm seeing a question from the advisory group. Could you please discuss the plan to harmonize with the existing breast cancer screening measure? Is there a reason why this measure doesn't include screening for all, and if positive, patient receives timely follow-up?
I'll start that one, Brenna, if others want to chime in, by all means. The current breast cancer screening measure is really geared more toward, I'll say, primary care. So, family practice, internal medicine, OBGYN. So in other words, the person initiating the order, if you will, for the mammogram. They really would potentially have their hands tied in terms of they could call the patient the day they get the report back and, recommend follow-up, but they are going to be limited by the availability of the radiology group. Now, some might argue, well, so is the radiologist, but I would respectfully say that's not the case. Patients, that need to be added in can be added in if a radiologist, takes the initiative to say, hey, just put this patient on at the end of the day or what have you. They have more control over it because it's their practice. So not complete, but more control. And one other comment, because this was a lot of folks were talking about at the individual clinician level. I would suspect if this measure were reported, and again, this is just an educated guess, that most people would be reporting it at the group level and not at the individual level. Back to you, Brenna.
Thank you very much. Okay, Dr. Klein, did you want to respond to something?
Yeah, hi. I want to respond to many things. So thank you very much for. I'm sorry. Are you hearing me okay?
Mm-hmm.
I'm sorry. We have multiple computers, so we're at echoes. Let me see. Hold on a second. Oh, it's me. Yes, you have to put yourself on mute. Sorry, we're technologically challenged here for a second. Yeah, I'll just go to a different room.
Okay.
You good? Yeah. You good? Okay. Sorry about that. We are great health policymakers and so IT people. Several things to respond to. I think first, I think that we are sympathetic to the point that if a woman has a mammogram at age less than 40 for whatever reason that occurs, a palpable mass or something else, that should be included. I don't know what the issues are, the technology around getting that done, but I think intellectually we are sympathetic to that point. I would respectfully disagree with Rich Heller and other folks who say this is not in a radiologist control. So radiologists, whether they're in their own practices, whether they're contracted with a hospital, are the ones providing the mammograms. They are the ones seeing the results. They are the ones scheduling the follow-up. So it's, I guess the nicest way for me to say this, I disagree gently that a radiologist or radiology practice would not have control on how rapidly that person would come back. I'd also mention that since we're talking about Medicare patients at this point, there are no prior authorization issues at this level, unless it's, unless the measure changes. And then I think the final thing I would say, and please forgive me for being passionate, there are many women on this call, and those of us who are men have mothers, sisters, wives, and daughters. And it would be hard pressed for me to imagine sitting with either ourselves personally or our family members and knowing there was a suspicious mammogram and not being able to resolve that issue in 2 months because of scheduling issues, or whatever issues there are. So I really think this is a quality of care issue. I really think this is a patient sanity issue, for lack of a better way of putting it. Anxiety. And I really do think this is in the radiologist's control, whether it is the radiologist directly or whether it was simply having a meeting with a hospital operations people to say, we need to do this better. So with that, I thank you, and I will pass it on to the next person.
Thanks, Ron. Let me just go ahead and summarize what I've heard up to this point, and then we can decide if there's more that we need to discuss before taking it to a vote. So what I kind of heard from across public comment and both committees is that there's no question that this is a high importance issue and a quality of care issue, and a complicated one that is underrepresented in the program currently, that there is a gap there. What we did hear was some disagreement about the extent to which this is within the radiologist's locus of control. Hearing on one side that a lot of the reasons that follow-up care would be delayed are things that are more systems level or even at the patient level, delays on their side. And there's some concern among radiologists, maybe a lot of concern among radiologists that they would be held accountable for things that they can't control. On the other hand, as we just heard from Dr. Klein, there are still things that clinicians can and should do in order to ensure that they are getting patients in a timely manner for follow-up on suspicious mammograms. We also saw quite a bit of discussion around the technical feasibility of this measure. It has been tested. It is an ECQM, which in general is associated with lower burden. However, there's some question around how these BI-RADS are stored in the EHR and how easy it is for sites to actually collect and report on that information. So I'm going to pause there. I think that sort of summarizes what I've heard. I want to give individuals an opportunity to just tell me if there's a point that I missed, something that you want to emphasize further. Yeah, Anya.
Hi, good afternoon, everyone. Thanks so much for all of the feedback so far. I just wanted to take an opportunity to talk about the feasibility of the measure. And I did want to point out that Epic and Cerner do have discrete fields to collect the BI-RADS information. And all three sites, all three health systems where we tested, there were specific cases where we did have to apply the string search algorithm. So we developed that. It showed 100% accuracy. You can take a look at the published literature. There are many different algorithms available to pull with very high accuracy BI-RADS results from reports. And although they're not in structured fields, they are in electronic fields where you can pull it quite easily. And there are currently other measures that have been endorsed and passed the final rule that do use NLP for extraction. So I just wanted to highlight that to make sure that everyone's aware that this is a possibility and has been used in ECQMs that are currently available for 2026.
Thank you. And can you also just clarify for folks, there's been a little bit of discussion in the chat about the attribution, so the distinction between radiologist and ordering provider.
Sure, absolutely. So this measure would be at the clinician level for the radiologist. So we find that once you are in the clinic and you've gotten your screening mammogram, then it would be the responsibility of the radiologist to follow up. We do recognize that most people would be reporting at the group level, not at the individual clinician level. And this is one of the main reasons that this could particularly fit really well into MIPS value pathways, where it's more likely that you're reporting as a group rather than an individual clinician. So, as we're talking about this is a really important measure. We need to make sure people are getting in on time. We have this screening measure, so the breast cancer screening measure that we've harmonized with as appropriate. And so that talks about whether or not people got their initial screening, but we need to ensure that people complete the screening cycle. And so pairing those two measures together has incredible value to make sure that we identify breast cancer early in a way that we can actually intervene and increase quality of life, increase survival, and quality of care overall.
Thank you for that. I'm going to turn it to Raina for her last comment. But in the meantime, we have a comment in the chat from Michael that has a question for you, Anya, if you don't mind responding to that in writing. That would be great. And Megan, go ahead.
Yeah, and my question I think is for Anya and maybe CMS. I think because I just want to make sure I heard that correctly and if this could be clarified. I think the string search that you were talking about, I want to make sure that that search is appropriate and consistent with how CMS allows ECQM reporting. I think that would clarify a lot for me if that string search would be consistent to the ECQM reporting.
Yeah, I'll defer to CMS.
I think we'd have to take that offline and get back unless Michelle's able to comment on that.
Yeah, I think Corinne sort of rephrased it in the chat, which might be helpful. So the question is whether the current MIPS requirement is that there would be end-to-end reporting from EHRs without any manual manipulation. So the question is that the case or not?
That certainly was the case when we were giving bonus points for EHR reporting. But again, I would need to we need to get back to you guys on that question.
Okay. All right. So we're still seeing a lot of back and forth on like in the chat related to some folks wanting to see additional testing, but we're also seeing a counterpoint from a radiologist, from Dr. Friedland, saying that at every site I've been associated with, it's the system or practice that's responsible for follow-up, but that doesn't mean that the radiologist is not ultimately responsible for ensuring the system works well for patients. So thank you for sharing that perspective. That's helpful. So I think there are some technical questions about this measure that we could spend a lot of time diving into, but what we really need to sort of get at today is a vote as to whether or not this measure would be a net benefit or a net harm to be put into MIPS. So Jennifer, if you want to just get your comment out there, and then I do think we should probably take this to a vote.
That sounds great. Yeah, before voting, I really do want to understand the individual versus group level, because I think that's essential to me making a decision on the vote. So it sounded like correct me if this is not right, but it sounded like this was reviewed only at the group level when it went through the first process, but now it's been tested at the individual level. Is that right? Just clarify. Could you just please clarify that?
Yeah, CMS, do you want to, or Anya, do you want to take that?
Yeah, Anya, you want to grab that?
Sure, absolutely. Yes. So based on submission to the MIPS program, we conducted the feasibility, reliability, and validity testing at the individual clinician level as well. So initially, when we went up for endorsement, it was at the facility group level, which is the group level here. And then we conducted additional analyses at the radiologist level. And then the level of attribution would be based on how, at which level the clinician chooses to report. So if they choose to report at the individual clinician level, that's where the attribution would lie. If they choose to report at the group level, that's where the attribution would lie.
Okay, thank you. And then just to clarify that individual level testing, it looks like in the document did meet the 0.6 threshold.
Yes.
Is that
it
correct?
did.
But that's sort of like more late breaking than when it went through the endorsement process. Is that received?
Absolutely.
Thank you.
Yes, but we were able to show strong reliability at the individual clinician level as well.
Okay, thank you. That helps a lot.
Great.
All right, so unless I hear an objection from my co-chairs, I think we will take this to a vote.
I think that's reasonable. Clearly, this was a very passionate and robust discussion. I think the majority of things, including the 60-day timeline, have been answered in the chat. So I think that's reasonable.
All right. Let's do it.
Agree.
All right, the question should be up in a second. Voting is now open for measure 42, rate of timely follow-up on abnormal screening mammograms for breast cancer detection. Do you recommend including this measure in the merits-based incentive payment system? The options are A, recommend, or B, do not recommend. And again, if you're voting for B, please provide a rationale in the next tab. And we are expecting 28 votes. We have 24 in so far. Waiting for 2 more votes. All right, while we wait for the last vote, Brenna, we can move forward.
Thanks very much, and thank you, everyone. We got through that pretty efficiently, so let's just move right into the rate of timely follow-up on positive stool-based tests for colorectal cancer detection. This is MUC 2025-043. Let's go to the next slide. So this is another ECQM that reports the percentage of patients from 45 to 75 years old that have at least one positive stool-based colorectal cancer screening test during the measurement period, which is a calendar year, who completed a colonoscopy within 180 days after their first positive stool-based test result date. This is another process measure at the clinician, at the individual clinician level, facility level. Similarly, it was also endorsed with conditions during the fall 2024 cycle, and it's being proposed for MIPS. And with that, Dr. Green, I will turn it to you to give the CMS rationale for this one.
Thanks very much, Brenna. So this measure, as you can imagine, was also developed by Brigham and Women's. It is an electronic clinical quality measure. We don't have any that relate to, we don't have any measures that relate to timely follow-up for positive stool-based screening tests. It is consistent with the Meaningful Measure 2.0 framework, and it is a healthcare priority of wellness and prevention. We could consider this measure for the gastroenterology MVP. The median performance score was 57.5% with a range of 45 to 78%. Excuse me. Additional testing at the clinician level may be needed for MIPS implementation. CMS believes 180 days actually is too long a time frame, but it has not been tested with a shorter time frame. So the measure we're considering today, at least, is 180-day time frame. Brenna, with that, I think I will pass it back to you.
Thank you very, very much. All right, so let me just run through some of the public comments that we got for this measure. I want to sort of point out that there were 8 comments on this one, and that while this measure sort of looks structurally like the last one, the sort of tone of the comments is a little bit different. A lot of supportive themes in the public comment that we got on this measure. So we heard from a patient partner who described that they had failed a stool-based test years ago, and due to financial constraints, didn't go forward with the colonoscopy at that time, and now better understands the benefits of having an earlier colonoscopy. Because when she finally did, she found out she had a large mass and subsequently had a foot of her colon removed, along with 15 nodes. The earlier somebody is able to have a colonoscopy rather than later can be beneficial as well as life-saving. And she felt that 6 months was a reasonable time frame for measurement, as many people might have to save up to even have the colonoscopy or to plan ahead to have time off of work. And there could be multiple reasons that a colonoscopy is delayed by a few months, as well as workforce shortages, including available gastroenterologists, and really felt like this was structured in a way that made it worthwhile. We heard from a doctor that strongly supports CMS's efforts to implement a novel measure to ensure timely follow-up on positive non-invasive tests for colorectal cancer detection, and that improving accountability for colonoscopy completion will provide a critical incentive to improve timely access to care for patients. We heard from the Society of Gastroenterology Nurses and Associates that they strongly support the inclusion of this measure, and that by incorporating this measure into MIPS, CMS is acknowledging the importance of closing the gaps in care and advancing quality improvement efforts in this area. We heard from a group called Geneoscopy that they view this measure as an important and encouraging acknowledgement of the critical role that follow-up colonoscopy plays in the colorectal cancer screening continuum. And we heard from the Nevada Cancer Coalition, again, that they are strongly in support of the proposal to add this measure into MIPS, and there's in support of that 180-day timeframe. The only sort of concern themes that we heard was just a recommendation that providers get credit for documented outreach and navigation efforts, and alignment with payer prior authorization timelines, just to avoid penalizing providers for delays outside of their control. And then we also heard a recommendation for CMS to refine this measure. So first, to expand the measure to include all covered non-invasive CRC screening tests, not only stool-based ones, and also to shorten the baseline follow-up interval from 180 days to 90 days. So overall, a lot of support, and even the refinements seem aligned with what Dr. Green described as being the overall vision for this. Let's just go to the next slide really quickly so that we can see the closing care gaps considerations. When we think of age, we know that older patients are at an increased risk of perforation. So when considering colonoscopy, older patients and their providers have to weigh the risk of complications and comorbid conditions, just something to factor in. In terms of geography, distance, and transportation are known obstacles to colonoscopies for colorectal cancer screening in rural communities, which may be somewhat mitigated by having that longer interval between the index screening and the follow-up. Legislation has required private insurance to cover follow-up colonoscopy after a positive screening stool test, but Americans without insurance are unable to benefit from these policies. And then also language, adults with limited English proficiency are less likely to be up to date with colorectal cancer screening than others. So lots of considerations there, things that this measure might be able to address. With that, let's go back to the description slide, and I will open it to our advisory group members to help flag any priority topics for the discussion. I'm not seeing hands raised, so just in the interest of time, I'm also going to open the floor to our patients. Yeah, Corinne, hang on 1 second on yours. I just want to give the AG an opportunity to weigh in before I open it to the recommendation group. Reggie, go ahead.
Yes, I am supportive of this measure, and when I first looked at the time frame of 180 days, I was thinking that was way too long to get feedback. And my first thought was, did it get lost in the Postal Service? But one of my committee members, Mr. Lee, had a very good question that I would like to see answered regarding this. See, can developer confirm if the eligible population is consistent with the existing colon cancer screening measure? And if the developer can answer that question, that would be great.
Thank you, Reggie.
Thank you.
So we have harmonized with the existing colorectal cancer screening measure as appropriate. So one of the key differences is that if someone has a positive stool-based test, sorry, let me take a step back there. So it has been harmonized as appropriate. Our focus is on non-invasive testing. So, for example, if someone has a positive stool-based test, then they would be included in our denominator. But if they have, for example, a different type of test, such as CT colonography, that is an imaging test, which then you would have CRADS results, so CT colonography, radiology, and data system results. And those would specifically tell you what your follow-up should look like. And so if that imaging shows that you, for example, should have a follow-up colonoscopy within 1 to 2 weeks, we don't include that in our measure. So we look at those who had a positive stool-based test that require short-term follow-up with a colonoscopy, which is very different from other, non-colonoscopy tests that are available for screening. So there are some differences between the denominator population for the colorectal cancer screening measure and our measure. We focus on a very specific subpopulation of that measure that really, it's difficult to get people in for a colonoscopy. And so that's the focus, to get them in for a colonoscopy on time because it's required. And they need that follow-up to diagnose colorectal cancer in a timely way if it's present.
Thanks, Anya. Okay, before I open it up to the larger recommendation group, Corinne, I saw your comment about the AMAs. I apologize. I do my best to get as many of the sort of key summary points into the public comment summary. But if you want to just go ahead and sort of reiterate the AMA's public comment before we jump into the larger discussion, you can feel free to do that now if you like.
Yeah, sure. Thank you. I can do it now, or was gonna kind of summarize it right when you opened up for recommendation group.
Now's good.
We have concern because it was endorsed at the facility and integrated delivery system level using hospital outpatient and integrated delivery system data, and this is being proposed for individual clinician and group level use, and additional testing information is needed. I'm concerned that even with testing, it will likely not achieve acceptable reliability rates. And also I saw reading through the materials, the measure steward does not recommend the measure be used at the individual clinician level. So that would also be helpful if Brigham could clarify, due to the very low sample sizes and some of the signal to noise ratio. While it was acceptable at the group level, it's they used it looks like 2 years of data with a really larger sample size that I don't think is achievable at the clinician or facility, smaller practice level. And, as a reminder, in MIPS, you just need a minimum of 20 patients to set a benchmark. And then given the disconnect, could really have denominator counts that vary from year to year based on the rate of patients who choose to use a non-invasive screening test and subsequently test positive. And also overall concerned that the measure will miss a portion of the population at risk because it currently only includes positive stool-based tests and doesn't capture blood-based colorectal cancer screening tests that have been approved by the FDA.
Thanks for summarizing that, Corinne. So, all right, let's open the floor to the entire recommendation group. And just in the interest of time, Anya, if you guys want to start replying to any of those items point by point in the chat, feel free to do that. But Reggie, go ahead. Oh, I'm sorry, you already dropped your hand. Was that an accidental? It looks like it. All right, Jeff. Okay, sorry. Jeff, go ahead.
Okay. So I think there remains the attribution issue. I think that could really differentially hurt individuals in rural communities where access to follow-up services, colonoscopy, is not available, or more urban communities. I think at the integrated health system level, it makes great sense. But I'm worried that at an individual clinician level, we don't have, unless I've missed it, the reliability data. And I think conceptually, it's hard to accept the accountability at a primary care clinician or gastroenterologist to account for some of the things that are perhaps well beyond their control. Thanks.
Tipu, go ahead.
Thanks. Again, related to attribution, if this is for the ordering provider, I think these stool-based tests are mostly going to be ordered by primary care clinicians, and the follow-up colonoscopy is a real issue. I mean, in some areas, it's they're scheduling even the screening colonoscopies up to a year out, and so I think that's a real challenge that the ordering providers have little control over. Obviously, I mean, they can advocate within their systems and practices, but that's a real disconnect between ordering a stool-based screening and then needing to make sure that the follow-up colonoscopy happens.
Go ahead, Jennifer.
Thanks. Yes, I just haven't seen a answer in the chat. Oh, just now, attribution would be at the ordering provider level, but it's not recommended at the individual. That's super helpful. I want to also just add a comment that because these are at-home tests, we are seeing lots of entities order these and send these to the patient's houses. That is even outside of the PCP's office. And so I want to call attention to that there are even some health plans that are sending Cologuards to the patient's office, and that's even outside of the physician-patient relationship. So I think that attribution is really important to consider, because if a primary care physician didn't even order the Cologuard and it comes back positive, just because they're attributed to that primary care physician doesn't that is completely outside of the control of that physician. Thanks.
Thank you for that. I'm just looking at some of the questions that are being answered in the chat. So while I wait for others to raise their hand, sort of the response here is that 180 days offers the opportunity to get patients who need additional time in from days 90 to 180, since the overall rates are moderate at that time. And then we did see Wei from the recommendation group did report out the reliability findings. So Jeff, you had said you hadn't seen any. So she kindly put those in the chat. There is a bit of a wide range from 0.2 to 0.9. But there is some data, and that's in the PA as well, if you want to take a look at that. Yeah, Jeff, go ahead.
Yeah, just in response to that, those are at the facility level. And again, I'm concerned when we transition measures from a facility or health plan level or system level that we go back to the clinician. We don't know whether that's going to be as reliable or not. In fact, it's probably not going to be as reliable given the relatively smaller numbers of patients, smaller denominators. But in any case, I think the issue of our moving from a higher level like the system to the individual clinician and then saying, well, it's MIPS, and therefore you can choose to report or not to report. It's a slippery slope, because as we move into MVP, a lot of these measures are likely to be carried over. I certainly agree there should be timely follow-up of colonoscopy or appropriate evaluation, but I'm concerned about the reliability and validity in some cases. Thanks.
Thanks, Jeff. Okay, I'm still seeing a lot of like just technical commentary in the chat. And Anya, thank you so much for the timely responses that you're providing there. So for folks that still have ongoing questions, that's a good place to go. But what I don't want to do is just sort of rehash the same questions over and over. So I am going to just, again, summarize what I've heard so far so that if there are additional points that need to be brought to the group, that we can do that. So again, we've heard the public comment was overwhelmingly positive about this measure. Again, very strong acknowledgement both in this committee and in the public comment that timely follow-up is absolutely crucial to preventing worse outcomes for patients with colorectal cancer. And then the sort of question here comes down to the same questions that we've heard before. So on one hand, there are some folks that commented that 180-day window is too broad for follow-up and that people should be getting in sooner. But others have said that that's sort of a reasonable time frame given how difficult it can be and what system level factors there might be preventing people from coming in for that follow-up. So sort of two different sides of the same coin. We've also heard again, common concerns that we hear kind of across MIPS measures around individual level reliability and whether or not it is sufficient for being used in the program. So I think those were kind of the major points. I'd be interested in hearing from folks if there are other items that you want to elevate up for discussion or for highlighting before we vote. Yeah, Deepak.
Yeah, no, sorry. And again, full disclosure, while I was not involved with this measure, I am a gastroenterologist and in terms of the practice. So just cautious about any bias that's unintended with this. But I think, thank you very much for summarizing that, Brenna. And I think you highlighted that many of the positive points. I just wanted to note that in the comments, at least three of the societies, the AGA and the ACG, and AMA and their comments, which I think were outlined as well, just so for fairness as well as one provider to note. Regarding the timeline, again, I appreciate, and I think this is, I think Daniel mentioned this, others have noted, and psychologically, wait time is long of 6 months. However, in practice, and in fact, studies, at least in the European literature, have shown that finding from a positive test, granted it was in FIT, really did not show increased rate of advanced cancer, even up to 2 years. Having said that, I think this is a reasonable time frame for consideration. And I guess the last thing I would just note, and again, this is where I want to be careful again of bias, but like many specialties, we are facing issues with physician shortage. So and clarifying between the health system versus the individual is key, which many folks have raised, namely from the point of view that you have an ordering provider that might be engaged in this, and Dr. Woodward had mentioned there are also several competing entities that may send out these tests, and then who ultimately is responsible. From most of us in GI practices, it's open access endoscopy, so we necessarily may not have full control of the schedule. We have guidelines in terms of triage processes, but they may very well get scheduled beyond that time frame as well. So that's more the practicality as well. And yeah, so those are the main comments I just wanted to make. And Anya, I think you had a comment. So
before you jump in, Anya, I just wanted to quickly ask some of our patient participants that we haven't heard from yet. So Krista, Heather, Jennifer, Mary, if you guys, it's okay if you don't want to speak up, but if there's anything you would put in the chat for consideration, I think that would be it'd be helpful to get the patient perspective on this one. And in the meantime, Anya, yeah, go ahead.
Great, thank you. So I am trying to keep up with the chat and keep up with the conversation as well. So I'm doing my best here. I did want to touch on the 180-day time frame because I do know that has been a large topic of conversation. And the application of a 90-day timeframe has been proposed because we do see it trailing off at 90 days. So it seems that those people who are getting in within 90 days, and that's going really well. But we do have a large subset of the population, sometimes up to 50%, who are not even getting in within 180 days. And so based on the literature, we know that there is a direct clinical impact on that patient population, like a significant effect on patient outcomes if they do not receive their colonoscopy within 180 days. So one of the key things that this measure really does offer is it creates pressure to get people who didn't get the colonoscopy in that extra space between those 90 to 180 days. And you could see a lot of value from filling that gap as well. So it's not necessarily just shortening it for the people that are the 50% of people or 65% of people who are already getting a colonoscopy, but really having that extra time to get additional people in to get their colonoscopy within 180 days before significant impacts can occur for the patient outcomes. So in terms of reporting at the individual clinician level, we did do the testing, and there is a small sample size issue with reporting at the individual clinician level. So we just wanted to, really support this measure at the group level. So reporting at the group level, and it could, again, be a really good fit for MIPS value pathways. So those are most likely to be reported at the group level and less likely to be reported at the individual clinician level, just based on everything that's required within those comprehensive bundles. So this would be a very good measure to pair with the colorectal cancer screening measure that already exists, just to really ensure that people are getting the colonoscopies that they need and identifying the colorectal cancer early.
Thanks for that. All right, Ron, do you want to give sort of a last perspective here before we vote on this one?
Well, thank you. A last perspective, perhaps a broader perspective, and this is true when it comes up for mammography. It's true for colonoscopy, and it comes up for a whole range of different issues. Right? We're all taught, triage, whether you work in an ER or whatever. That's a basic concept of clinical care. So, I certainly appreciate the long waiting times for colonoscopies. I mean, there should be some component of analysis here, or thought. Active thought maybe is the best way to put that, is that someone who has a positive stool screen probably has a higher priority than somebody's going to get their colonoscopy 10 years and 6 months rather than at 10 years. So while I do appreciate issues in access to care, we really have to include an active triage component in here and really say that those people need to be at the front of the line. And that I think, would address some of the issues that we're talking about. Thank you.
Thanks very much. Anya, is there something additional that you needed to respond to, or is it something that can go in the chat? Yeah.
There was just one more comment that I did want to respond to around the not having included the stool-based RNA tests or the blood-based biomarker tests at this point in time. So just to acknowledge that clinical quality measures in general do grow and evolve over time. So these are very new, novel tests that were very recently placed in the NCCN guidelines. And so the fact that they're not included now does not mean they will not be included in the future. And that just to consider that the measure will evolve over time.
Thank you, Anya. All right. In the interest of time, let's take this one to a vote. I'm going to turn to Isaac.
The question should be up in a second. Voting is now open for MUC 2025-043, rate of timely follow-up on positive stool-based tests for colorectal cancer detection. Do you recommend including this measure in the merit-based incentive payment system? The options are A, recommend, or B, do not recommend. Please provide a rationale if you're voting to not recommend this measure. And we are expecting 28 votes. All right, we have all 28 votes. Over to you, Brenna.
Thank you all very, very much. And thank you for those of you who shared your perspectives in the chat. Okay, we're going to go to the next slide, but I wanted to just ask, sorry to put you on the spot here, Dr. Schreiber. we're kind of at the end of the time that we had allotted for the measure discussion, and our plan was at the end of this meeting to gather feedback just on the process in general and then do a wrap up. I'm just curious from the CMS perspective, are you more interested in getting feedback on the process itself, or do you want to use our last 15 minutes here to get inputs on ACP?
Sorry, we were having a little bit of audio problems here. I want to just address a couple of things in ACP, and then people can put maybe comments into chat because we don't have that much more time. So Corinne, to your question earlier today, yes, you are correct. There is a measure in MIPS already. The difference here is that this starts at age 18. It's also a digital measure. The question is not the measure that was proposed on the hospital side. Should it be proposed on the MIPS side right now? The question really is, should this be in the MIPS program? In other words, do people, thanks Corinne for the question, are people in agreement with the concept of starting these conversations earlier? Should it be in the MIPS program? And I'll ask one further question. Should this be a mandatory question in the MIPS program because of how important these conversations are? So I don't know that we need an active conversation on it since we don't have a lot of time. But if people have comments and would like to share them in the chat, that's a wonderful opportunity to provide feedback because we would greatly appreciate it. CMS is considering whether or not to respecify some of the advanced care planning measures that have been up for discussion, say on the hospital side, if they should be respecified for other programs, MIPS being one of those, potentially other programs. Post-acute care, by the way, is the same question. And again, because of the importance of these conversations, we're just seeking feedback from the committee. So I will just pause at that because I know that you guys have other things to bring forward and I want to be respectful of everybody's time. Does that work, Brenna?
Absolutely does. So yeah, let's see all those comments in the chat. I'm seeing folks come through. And then I think we can go to the next slide. This is where I think my facilitation ends, and I'm gonna let Meredith and or Kate take over.
Yeah, we can go to the slide about collecting feedback. We are interested in getting your thoughts on what went well this cycle, what could have gone better. You can advance actually to the next slide with some just thoughts on what you might be interested in commenting on. We're open to your feedback and thoughts now. However, we will also be sending you a survey to complete so you can provide your thoughts there. So just open space for a couple of minutes if folks had any feedback for us on what went well or what could be improved upon next time. Now would be a great time to share that. Diane, yes.
Thank you. This is my first time going through the process, and I have to, first of all, say terrific session today. You ran this very well. I liked the structure, the sharing of the information and the different sources. I think the only recommendation I would have is for future cycles is it was very challenging to, the timeliness of information coming to us in preparing for this allotted a couple of hours, whether it be public comments being shared with us or invitations for dates that we needed to modify in our own calendars because everyone's busy. So it was just a bit challenging for me was the timeliness.
Thank you for that.
Let me just comment on that on Batel's behalf, perhaps in their defense. Some of this was due to the government shutdown, so that we weren't able to provide all of the information to Batel in a timely manner. And as you know, the MUC list was delayed again for the same reasons. So I just do want to comment that there were extenuating circumstances. Not that we don't agree with your comment, but just so everybody recognizes some of the circumstances involved.
Thanks for that. And just want to add, we know this is a very busy time of year with holidays and family obligations and et cetera. So we are especially grateful for you all making the time to participate in our activities. Jeff.
Yes, I'll just echo the timeliness of communication. I recognize the shutdown had a huge impact, but if we can get on our calendars when we anticipate the next sessions to be way in advance, that's extremely helpful. The other issue I'd raise is just having a better description of things like reliability when it's been tested in one population, but then is being proposed to another. I think that's tripped up at least my willingness to recommend some of these. And a better understanding of CMS's process here. If you're moving to MVP or a different way of using some of these measures, I might be more supportive. But when we're talking about it also allowing or specifying individual clinicians, it's a different story for me. So just thinking about how we conceptualize this and get through the discussion more timely. Thank you.
Appreciate those comments, Jeff. Thank you. And let's see here. Corinne.
Thank you, and thank you for all the work that went into this meeting and putting the materials together. I know some things were more challenging due to the shutdown, but if we could have the public comments provided to us earlier, not the day of the meeting, I think it would also help with the flow of the conversation and discussion, because they commenters bring up, important points that are needed to be discussed, and also provide the developer the opportunity to respond as informed as they can be. Also, if we could have consistency in terms of testing and what's required, because it does appear there's some inconsistency in terms of what CMS considers acceptable testing for a measure to be considered on the MUC list. I know what the AMA had to go through when we put forward a measure last year, and we were specifically required to include testing at the appropriate level of analysis, but today we saw several measures that were only tested at a different level of use. And as Dr. Sussman highlighted, that really makes conversation and discussion of the measures difficult, and being able to appropriately consider the measure. Thank you.
Thank you so much for that feedback, Corinne. We appreciate it. Megan.
So having been on the recommendation group for the last 2 years, this is my third meeting. I do think this was probably, for the clinician, it went smoother than in prior years, absolutely. But I'm guessing part of that is because we had less measures this year than we have in the past. And so maybe that's also just a consideration too, the number of measures that are brought to the group. It is easier to digest and make sure we get into good conversation when not have to sit through a really long meeting as well. I know that can also be challenging, to have a meaningful conversation.
Thank you. Question for the group, if I may, Meredith. What did people think of the new voting arrangement and the categories?
You just need a little bit more time because of the added requirement. If you vote no, you have to put the justification. So things move a little bit too quickly. Otherwise, it was fine.
The categories, because it's different as you all saw this year. It's consensus yes, consensus no, didn't reach consensus, but we support, didn't reach consensus, but it looks like no support. So it's a little bit different than it has been in the past.
Yeah, it's hard to tell. Things moved kind of fast in the voting part, and then not a clear understanding on the direction of how things were voted on.
Thank you. And I think Jeff just raised a question in the chat that is a nice segue. We do have slides with our results on the next slide, so we can share those. So this is sort of where we landed today. So you can see for the first measure, the committee reached consensus agreement to recommend the measure. That's the LDLC monitoring and management measure. For the abnormal screening mammograms for breast cancer detection rate of timely follow-up measure, consensus was not reached, but the majority of the committee expressed some support for use of the measure. And then for the timely follow-up on positive stool-based tests for colorectal cancer detection, the committee did not reach agreement on the use of the measure in MIPS. So that's where we landed today, and thank you for your wonderful contributions to the discussion in the chat. We really appreciate it, and I'm going to turn it over to my colleague Kate to walk us through some next steps.
So much, and thank you all. So if we go on to the next slide. So we will be in our meeting summaries, you'll be getting a little bit more information about the different conditions and suggestions that people had. All of that information will be there, so we'll be listing it out. We'll also have a summary of it within the recommendation group spreadsheet that will be available to go one slide back. On January 30th, that will initiate a second public comment period from February 2nd to February 16th. Doesn't change the recommendation outcome, but it does provide additional data points for CMS as they continue on through rulemaking. So our final meeting summary and recording, in case you want to go back and relive the highlights, will be on February 12th. And our final MUC recommendations report will be published to the PQM site on February 25th. So you will be getting all of those different rationales and recommendations, that information when we release the spreadsheet, as well as the meeting summaries and report. Looking through if I got any questions on that. Don't think so. So want to reiterate my incredible thanks for this effort and your time. Not possible without you. And thank you to our co-chairs. Thank you to CMS and the measure developers and stewards for being on their time. Thank you to the Battelle staff for making this run so smoothly. Dr. Schreiber, can I hand it off to you to get any closing comments?
I think they're going to echo pretty much what you guys have said, and that is a big thank you to everybody who has participated. Thank you to Battelle. This has been near the third day of doing this, by the way, for those of you who haven't been on other calls. And so it has been an enormous task, and you guys have done a wonderful job. To all of you who have participated, we deeply, deeply appreciate all of the comments and feedback. I always learn something from these conversations, and today is no exception. And to the CMS staff, contractors, and measure developers, who are takes a great deal of work to put these together and be working on measures throughout the year. So a large thanks to that. In the end, obviously what we're trying to do is make American healthcare better for all individuals and have transparent reporting so that consumers can make informed choices and transparent accountability. So thank you all for your contribution to advancing policy making.
Thank you, Dr. Schreiber. And you were a little fuzzy, but we did hear that there were kudos all around. So I think we can take that. So we can hold on to the kudos all around. And
we'll go with that.
There we go. So thank you all, and I will see some of you in a couple of minutes. But thank you all so much.
Thanks all. Take care.